Comlex Minute, please visit our website at www.comlexflashcards.com for even more information on how you can prepare for the Comlex exam. Keep in mind these are short lectures designed to give you a quick update on certain high-yield sections for the Comlex. Let's review Pediatric Orthopedics today. For Pediatric Orthopedics, one of the classic scenarios is a child with a limp, and you want to focus on the age. Patient from birth to 3 years of age, you're thinking developmental dysplasia of the hip. Patient between 4 to 12 years of age, you're thinking Legg-Calvé-Perthes disease. And a patient who is greater than 12 years of age, you're thinking about slipped capital femoral epiphysis. Again, with developmental dysplasia of the hip, you're going to look at the Barlow-Ordolini test and the Galeazzi sign. And in order to make the diagnosis, the best test is an ultrasound of the hip. And after 4 months, you can do a frog lateral x-ray. Okay? The treatment is generally dependent on the age of the patient at diagnosis. Some patients do benefit from pelvic harnesses. Again, in developmental dysplasia of the hip, one of the complications is acetabular dysplasia, and so you want to be careful about that as well. Again, for Legg-Calvé-Perthes, a 5-year-old boy who has progressive limping complains of anterior thigh pain. This is actually an idiopathic avascular necrosis of the capital femoral epiphysis. Patients typically have a painless limp, okay? And again, looking at the age, you're going to narrow down your differential diagnosis. Let's talk about slipped capital femoral epiphysis. Here the key words are obesity, okay? An obese person should clue you in on slipped capital femoral epiphysis. Also, keep in mind that hip pathology typically refers pain to the knee. And again, here's a question that asks us, what is one of the common complications of slipped capital femoral epiphysis? Well, it's osteonecrosis, which is avascular necrosis, and also degradation of cartilage called chondrolysis. For diagnosis, you can get AP and frog lateral x-rays, and you're going to see this characteristic ice cream cone sign near the acetabulum. And so these 3 diseases are important to know when you're preparing for the Comlex. They're very high yield. Now, patient comes in and you examine their foot. It's medially rotated. It's very stiff. And also, you notice a medial rotation of the heel. What are you thinking about? Again, the answer here would be talipes equinovarus, which is clubfoot. And in this disease, the patient's heel can't go flat on the exam surface, as opposed to metatarsus adductus, in which the heel can. And this is a congenital positional neuromuscular disease, but it's important to know the differential diagnosis in terms of patients who present with in-toeing. Again, another question that's going to be very high yield is osteosarcoma versus Ewing's sarcoma. Okay, and in this condition, you want to make sure that you look at the patient presentation and a characteristic sign on the x-rays. Osteosarcoma will present with a sclerotic destruction showing a sunburst appearance, whereas Ewing sarcoma will typically have a lytic, laminar periosteal elevation called the onion skin sign. Here's a question. In osteosarcoma, what malignancy is it most common associated with? And the answer here is retinoblastoma. And so it's important to keep in mind these things while you're studying for the Comlex. Again, here's another question. True or false? A Baker cyst is a non-pulsatile painful distension of the bursa by synovial fluid behind the knee. Actually, the answer here is false. The key thing here that you want to remember is that the Baker cyst is typically non-pulsatile, but it's painless. Okay, that's the key word here. And let's review the Baker cyst. Here's a picture showing you the Baker cyst. It's typically, in the middle childhood. It causes a distension of the bursa by the synovial fluid behind the knee here. And you generally, get an ultrasound for aspiration. Most of the time for patients who have had it for less than 10 years, no treatment is generally required for asymptomatic Baker cyst. There is, however, a role for surgeries if there's an enlargement. but in children it's typically not recommended. Let's review some of the surgeries that are common for Baker's cyst. You can have an arthroscopic treatment, which is reportedly successful in adults, and then again there's these three other types: common posterior approach, Hunkston's posterior medial approach, and medial intra-articular approach. But for Baker's cyst, the key thing is get an ultrasound and observe the patient for a while to make sure it's not enlarging. If it is, and it's more common in adults, then you may consider surgery, but for children, surgery is not recommended. And again, it's a non-painful condition. Okay, here's our references, and again, visit us at www.comlexflashcards.com, and we'll have full lectures on each of these topics very